Good day. I am Z.A.A. a third-year medical student from Brokenshire College School of Medicine. Today, I will be discussing the case of patient J.M., a 4-month-old Filipino female from Tugbok, Davao City, who was brought in for consult due to generalized petechial rashes. The patient was a well baby until 3 days prior to consult when the patient's mother noticed small, red, flat, non-blanching pinpoint macules on the face and on both upper and lower extremities with no associated symptoms like fever, cough, or weakness. As claimed, the patient was not irritable and still had good suck or feeding. The mother disregarded the rashes, thinking that it would resolve eventually. She denied use of any topical products on the patient's rashes. One day prior to consult, the mother noticed persistence of rashes but still with no accompanying symptoms. However, was now noted to be generalized and characterized as red, non-blanching raised macules. Hence, the mother decided to seek consult. The patient was born full term, weighing 2,750 grams, to a then 28-year-old G2P1 2001 mother via normal spontaneous vaginal delivery. The mother claimed that she had her regular prenatal consultations at their local health center and received tetanus toxoid vaccine and folic acid supplements. She denied smoking, drinking alcoholic beverages, and taking other supplements during her pregnancy. The patient had no known allergies and was exclusively breastfed until 3 months of age. The patient received 1 dose of BCG and hepatitis B vaccine and 2 doses of oral polio vaccine. The patient was second among 2 children in the family. They lived together in their own house, which was claimed to be of good water supply and sanitation. The patient's father was a company truck driver, while her mother was a housewife. Both the maternal and paternal side of the patient had a known case of hypertension. There were no other heredofamilial diseases known. However, the patient's older sister was diagnosed with idiopathic thrombocytopenic purpura or ITP at 3 years old. For the review of systems, the patient was noted to have non-productive cough 2 weeks prior to the appearance of rashes with no accompanying symptoms. The other systems were unremarkable. Physical examination revealed the following: vital signs, temperature of 36.6 degrees Celsius, heart rate of 114 beats per minute, and respiratory rate of 28 cycles per minute. For the anthropometrics, the patient's weight was 6 kilograms, height 61 centimeters with a BMI of 16.21 kilograms per meter squared. The head circumference was 40 centimeters, the chest circumference was 43 centimeters, and the abdominal girth was 46 centimeters. The Z-scores or interpretations were all normal. The patient was seen sleeping on her mother's arms and not in respiratory distress. The patient had a fair complexion with noted multiple red, slightly raised, less than or equal to 1 centimeter non-blanching, non-pruritic pinpoint rashes on both the upper and lower extremities. There were no other lesions or scars seen. The patient was generally warm to touch with good skin turgor. The head was normocephalic. There were no lesions, scars, redness, deformities, or tenderness noted. Erythematous rashes were seen on the upper back, and there were no lumps, masses, or tenderness noted. Both lung fields were resonant, and no wheezing or crackles noted. Adynamic precordium was observed, and there were no scars, lesions, masses, or tenderness noted. Regular rate and rhythm with no murmurs, heaves, or thrills noted. Round but not distended abdomen was observed. There were no scars, lesions, or redness noted. Normoactive bowel sounds were heard, and the liver and spleen were unpalpable. The complete blood count was taken, which revealed the following: based on the history, physical examination, and laboratory results, the pertinent findings in this case are generalized petechial rashes, positive family history of ITP, cough 2 weeks prior to the onset of rashes, no fever, no organomegaly, and laboratory result which revealed anemia and thrombocytopenia. Thus, the working impression is idiopathic thrombocytopenic purpura. Petty K are pinpoint non-blanching spots that measure less than 2 millimeters in size, which affect the skin and mucous membranes. It results from areas of hemorrhage into the dermis. Primary pathophysiological causes of petty K and purpura are thrombocytopenia, platelet dysfunction, disorders of coagulation, and loss of vascular integrity. A study by Barnettson et al. 2016 showed that most petechial rashes can be caused by three main etiologies, namely infectious, vasculitic, and hematologic in origin. Petechial rashes are commonly associated with viral illnesses. The presence of cough 2 weeks prior to the onset of rashes indicates that the patient had an upper respiratory tract infection. Dengue and measles, two of the most common viral illnesses endemic in the country, are considered in this case due to the manifestation of petechial rashes, which are usually seen in both. However, the patient was afebrile, had no other signs and symptoms, and the result of the CBC done in the patient presents otherwise. Hence, these diagnoses are unlikely. A primary vasculitic differential for a manifestation of petechial rashes is henochson line purpura. It is an acute vasculitis with an unidentified cause. It usually appears as a rash with joint symptoms, abdominal pain, and urinary abnormalities in children between the ages 3 and 10 years. Incidence of HSP usually peaks during the winter months, and it is commonly preceded by an upper respiratory tract infection. The pathophysiology involves increased levels of IgA and IgG, which forms complexes that activate complement. These are then deposited in the affected organs, causing an inflammatory response and present in the form of a vasculitis. Children usually have a fever at initial presentation, but the most noticeable feature is the characteristic non-blanching rash. Classic sites for the rash include the buttocks, the extensor surfaces of the lower limbs, and around the ankles. Platelet levels are normal in children with HSP, but the inflammatory vasculitic process damages the capillary, which allows leakage of blood into the skin and other tissues, resulting in rashes. In addition to fever and petechial rash, signs and symptoms of HSP include the following: arthralgia and swelling mainly of large joints, periarticular edema, abdominal pain and melena, proteinuria, hematuria and glomerulonephritis, testicular torsion, and intussusception. There is no specific diagnostic test for HSP, but the triad of signs and symptoms, a purpuric rash, arthralgia, and abdominal pain, are highly suggestive of the condition. HSP is considered in this case since the patient presented with generalized non-blanching petechial rashes with a history of an upper respiratory tract infection 2 weeks prior. However, because of the patient's age, absence of fever, joint, abdominal, and urinary symptoms pertinent in patients with HSP, this is unlikely the diagnosis of this case. Moreover, normal platelet count is noted in patients with HSP, which is inconsistent in this case. Hence, henochson line purpura is highly unlikely. With the manifestation of petechial rashes caused by thrombocytopenia as evidenced by the laboratory findings, hematologic differentials are of prime importance. Two of these are discussed on the following slides. Hemolytic uremic syndrome is a severe condition which accounts for 0.2 to 4.28 per 100,000 cases of pediatric acute renal failure globally. It is defined as the combination of a microangiopathic hemolytic anemia with variable degrees of thrombocytopenia and renal failure. The syndrome usually occurs in previously healthy children and often is preceded by gastrointestinal enteritis. HUS occurs predominantly in children younger than 4 years of age. The most common form of the syndrome occurs in healthy young children and is preceded by watery diarrhea that can evolve to hemorrhagic colitis. The clinical picture of HUS is a previously healthy child who develops abdominal pain and diarrhea, followed shortly thereafter by bloody diarrhea. There may also be fever. Within 5 to 7 days, the patient exhibits signs of anemia and thrombocytopenia. Other signs may include hepatomegaly, hypertension, oliguria, and CNS changes, and more severe gastrointestinal manifestations such as intussusception or gangrenous bowel. In this case, the patient's age, previous health status, presence of anemia and thrombocytopenia manifesting as petechiae all supports HUS. However, since the patient had no fever, abdominal symptoms, and did not meet the classic triad of HUS, this is unlikely the diagnosis of this case. Next is idiopathic thrombocytopenic purpura or ITP. It is the most common cause of acute onset of thrombocytopenia in an otherwise well child. In a small number of children, it is estimated that at 1 in 20,000 cases, 1 to 4 weeks after exposure to a common viral infection, an autoantibody directed against the platelet surface develops, with resultant sudden onset of thrombocytopenia, and a recent history of viral illness is described in 50 to 65% of cases of childhood ITP. The peak age of incidence is 1 to 4 years. Males and females are equally affected, and it seems to occur more often in late winter and spring after the peak season of viral respiratory illness. The exact antigenic target for most such antibodies in most cases of childhood acute ITP remains undetermined. On the other hand, in chronic ITP, many patients demonstrate antibodies against the platelet glycoprotein complexes. After binding of the antibody to the platelet surface, circulating antibody-coated platelets are recognized by the Fc receptor on splenic macrophages, ingested, and destroyed. Moreover, platelets become coated with autoantibodies to platelet membrane antigens, resulting in splenic sequestration and phagocytosis by mononuclear macrophages. The resulting shortened lifespan of platelets in the circulation, together with incomplete compensation by increased platelet production by bone marrow megakaryocytes, results in a decreased number of circulating platelets or thrombocytopenia, as seen in this case. The classic presentation of ITP is a previously healthy 1 to 4 years old child who has a sudden onset of generalized petechiae and purpura. There may be bleeding from the gums and mucous membranes, particularly with profound thrombocytopenia. There is a history of a preceding viral infection 1 to 4 weeks before the onset of thrombocytopenia. Findings on physical examination are normal, other than the finding of petechiae and purpura. All of these were evident in the case of patient JM. A classification system has been proposed from the UK to characterize the severity of bleeding in ITP on the basis of signs and symptoms, but not platelet count. In this case, although patient JM did not have minor epistaxis, bleeding, or bruising, she can be classified as Class 2, having mild symptoms of petechiae. In 70 to 80% of children who present with acute ITP, spontaneous resolution occurs within 6 months, and approximately 20% of children who present with acute ITP go on to have chronic ITP. The outcome or prognosis may be related more to age, as ITP in younger children is more likely to resolve, whereas the development of chronic ITP in adolescents approaches 50%. In acute ITP, the hemoglobin value, WBC count, and differential count should be normal. Bone marrow examination shows normal granulocytic and erythrocytic series with characteristically normal or increased number of megakaryocytes. Some of the megakaryocytes may appear to be immature and are reflective of increased platelet turnover. In treating ITP, there is still no data showing that treatment affects either short or long-term clinical outcome. Many patients with new onset ITP have mild symptoms with findings limited to petechiae and purpura on the skin, despite severe thrombocytopenia. Antiplatelet antibodies bind to transfused platelets as well as they do to autologous platelets. Thus, platelet transfusion in ITP is usually contraindicated unless life-threatening bleeding is present. Initial approaches to the management of ITP are the following. No therapy other than education and counseling of the family and patient for patients with minimal, mild, and moderate symptoms. Per the American Society of Hematology guidelines, a single dose of IVIG 0.8 to 1.0 gram per kilogram or a short course of corticosteroids should be used as first-line treatment. Prednisone of 1 to 4 mg per kilogram per 24 hour, and IV anti-D therapy. For the course of illness, 2 to 3 days prior to consult, there was the appearance of petechial rash on the extremities and face. On the day of the consult, the patient was seen with petechial rashes, was active, and had clear breathing with no jaundice and organomegaly. The patient was initially assessed as idiopathic thrombocytopenic purpura. The patient was then advised for peripheral blood smear and bone marrow aspiration, which revealed the following. On the second consult, the patient came in for follow-up with no subjective complaints. The patient was seen with no active bleeding and with multiple bluish discolorations or petechiae. The patient was still assessed as a case of infantile idiopathic thrombocytopenic purpura. The patient was then advised for repeat complete blood count with platelet count and to start prednisone 10 mg per 5 ml, 1.3 milliliters 2 times a day for 1 month, and ferrous sulfate drops 0.5 ml once a day and for repeat CBC after a week. Complete blood count revealed the following. On the third consult, the patient came in for follow-up with no subjective complaints. The patient was still seen with petechial rashes but with no organomegaly. The patient was advised to continue medications and to have a follow-up checkup with repeat complete blood count. The possible tapering down of prednisone and follow-up after 2 weeks was also advised. Complete blood count for the third consult revealed the following. On the fourth consult, the patient came in for follow-up with no subjective complaints and was seen with clear breath sounds. The patient was advised to reduce prednisone 10 mg per 5 ml to 1.3 ml once a day in 1 week, then to reduce to 0.7 ml once a day. Complete blood count revealed the following. On the fifth consult, the patient came in for follow-up still with no subjective complaints. The patient was seen with rashes on the extremities. However, there was no jaundice or organomegaly noted. The patient was advised to continue medications and to have the follow-up checkup the following month. Complete blood count revealed the following. As evidenced by the laboratory results, the patient's condition significantly responded to the medications given, particularly prednisone, which is essentially indicated for patients with ITP. As discussed, patients with acute ITP may have resolution of symptoms upon continued medication and monitoring, while those with thrombocytopenia of more than 12 months may progress to chronic ITP. In summary, this is a case of patient J.M., a 4-month-old female, a previously well baby who had a history of cough 2 weeks prior to the onset of petechial rashes with no accompanying signs and symptoms. The normal physical examination and complete blood count showing severe thrombocytopenia, which significantly responded to medications, and a strong family history of ITP is supportive of the diagnosis of idiopathic thrombocytopenic purpura. Again, this is Z.A.A. of Brokenshire College School of Medicine. Thank you for watching and may God bless you.